Hello and welcome to my presentation of my dissertation, which looks at suicide intervention training outcomes among mental health professionals. I'll start by introducing myself. My name is Jodie. I have a bachelor's degree in psychology with French. I'm coming towards the end of my master's in counselling at Bangor, and alongside that, I've been working for a number of years as a suicide prevention advisor for a national helpline. And during my time in that work, I supported many professionals who have often found still use a lot of stigmatising language or hold stigmatising attitudes towards suicide and generally approach the topic with a lot of fear. And I found that echoed on the course and out on placement as well, which is why it's really important to be exploring this topic some more. Why is this important? Well, suicide is something that affects the entire globe, but more specifically in the UK in 2023, there were 7,055 deaths by suicide registered, which is a staggering number. And behind each one of those numbers is an individual with a story. And suicide has such a ripple effect. It's estimated to impact around 135 people. So it's not just friends and family, it's an entire community that is impacted. And for each death by suicide, there's an estimated 20 suicide attempts, but suicide attempts are massively underreported because there's a lack of unified definition, but also it relies on the individual actually presented in a healthcare setting and it being recorded appropriately. And it's also estimated that 1 in 5 of us will experience suicidal thoughts at some point. But again, how do we measure a thought? Might be something that's fleeting or ongoing. But what I want you to take away is that suicide, the magnitude of suicide and how much it impacts the whole community. Some theories have attempted to explain the progression of suicidality over time, because that there are risk factors that might make someone vulnerable to experiencing thoughts of suicide, but they might not. So the interpersonal theory of suicides suggested that an individual will experience a thwarted sense of belongingness coupled with perceived burdensomeness, and then they acquire the capability of suicide, and that is said to be through exposure to pain over time and access to means. So that exposure and habituation to pain is not only physical but psychological. So it may be through repeated events or physical through self-harm or previous suicide attempts. Then the IMV model looked at more of the progression of that over time in that risk. So it set out a 3-stage model, so looking at pre-motivational factors, so life events, for example. Then the motivational stage considers things that may hinder or help or serve as protective factors. So whether someone's got social support, for example, might prevent that from escalating further. And then the volitional stage again looks at the capability for suicide, so whether it's access to means or previous suicide attempts, for example. But take a look at the references if you want to know a little bit more about the theory. Suicide risk isn't static, it's something that is so individual and complex and changes very, very quickly. However, suicide risk assessments are used commonly across mental health settings within the UK, even though they've been found for years to be very poor predictors of suicidal behaviour. So when you're assessing someone, you are assessing their risk at that very moment when they are in front of you, because that can change when they leave the door. And in fact, the National Confidential Inquiry of Suicide found that 82% of mental health patients who died by suicide between 2016 and 2021 were actually assessed to have no or low risk of suicide. And what's recommended by them is that mental health staff should actually be focusing on building rapport and adopting a collaborative approach to managing suicidality. But there's barriers to this within services. So stigmatising attitudes are still very prevalent amongst mental health professionals. And it's also said that within core training and counselling specifically, may not be sufficient enough to equip someone to work with suicidality, and even having more experience doesn't necessarily make you better equipped alone. And also clients are more likely to disclose this suicidal thoughts in an implicit rather than explicit manner, which is why it's important for us to be able to pick up on those subtleties in order to be able to respond appropriately. So I won't go into lots of depth here, but fairly recently, the UK government released the National Suicide Prevention Strategy, which in a nutshell says that suicide is everyone's business. Everyone's got a role to play regardless of your role or the remit of your service. And this has then informed NHS's England's Staying Safe from Suicide guidance, and similarly NHS Wales have come up with something quite similar as well. And all of these echo what I said in the previous slide about adopting that more collaborative approach to working with suicide. One way to work more collaboratively is through using a suicide intervention model. Now, there's lots of different training models out there, but the common features tend to work off the premise that anyone can prevent suicide. So models will tend to look at recognising the warning signs of suicide, might look at how to ask the question about whether someone's having thoughts of suicide, so then connecting with that person's story, so meeting them where they are and hearing their reasons for dying. And in doing so, you're allowing them space to think and connect with their reasons for living, with a view to that individual using that as a rationale to working towards staying safe for now. And that's where you'd be working collaboratively to create a safety plan. And within that, you're assessing the imminency of their suicide risk, potentially offering further signposts into onward support. And within the training model, it might also cover safe and non-stigmatising language to use alongside that. Suicide intervention training models are primarily being rolled out in community settings, but it's argued that anyone can be a gatekeeper. So research consistently shows that suicide intervention programs improve participant knowledge of suicide, their confidence, but there's mixed evidence in terms of whether it changes someone's attitude towards suicide. And some of the common models that are used are ASIST, QPR, and STORM. So STORM is used a lot in UK health settings, and then there's CAMS, and that one is a little bit more specific to more of a therapeutic setting rather than a community setting. So as I said, there's lots of research in community settings about the impact of suicide intervention training, but very few studies have looked specifically at mental health professionals. So the research question is, what are the outcomes of suicide intervention training programs among mental health professionals? This study was a systematic literature review, which followed the PRISMA guidelines. So keywords and Boolean terms were inputted across 4 academic databases. So there was variations of suicide intervention, suicide prevention, suicide gatekeeper, along with various different professions. So mental health professionals was the population we were looking at, but that included counsellors, psychotherapists, psychologists, psychiatrists, social workers, and mental health nurses. The reason that I'm looking more broadly at that is because there is such a limited amount of research in this very specific area, so broaden that out, so it's not just looking at counselling. So the intervention was suicide intervention training of some form, so it had to be a named intervention, it had to be an empirical study as well. The comparison was either pre or post test or a waitlist control. And then the outcomes we're looking at was improvements in knowledge, self-efficacy, confidence, and the skill application and attitudes as well. So once we'd gathered that, we looked at extracting the names of the authors, your publication, the model they've used, the population they were looking at, and most importantly, the outcomes. Then I've used a narrative synthesis to synthesize the findings, because there was a variation in study designs and measures used. Initial database searches yielded 440 records, duplicates were then removed, and titles and abstracts were screened. And after the full text screening, 9 studies met the inclusion criteria alongside 2 additional studies that were identified through manual search, which left 11 total studies, including the final synthesis. So what did we find? So participant attitudes generally significantly improved, particularly following STORM, NYSTS and ASIST. STORM participants reported that training gave them permission to talk about suicide more openly within their organisation. However, it was found after the QPRT training that it was not associated with any significant participant attitude changes. And some of the studies indicated that there was a variation in attitude change based upon seniority level of the mental health practitioner as well. Furthermore, looking at confidence and self-efficacy, so numerous studies found significant improvements in confidence self-efficacy, with some studies finding particularly large effect sizes as well. There was a qualitative study of people that used CAMS. They reported feeling more confident in directly addressing client suicidality as well. Furthermore, 4 studies reported significant improvements in participant knowledge. So that was across a range of different models. However, although the QPRT training generally improved participant knowledge, it was noted that there was no significant knowledge gains in the areas of risk assessment and safety planning. Within skill application and impact on practice, so there were 3 ASIST-focused studies and 1 CAMS study which reported improved skill acquisition, which was maintained at follow-up. The CAMS trained participants reported adopting more collaborative approaches to exploring client suicidality in their practice. And 1 study which was a double-blind trial of assist-trained and non-assist-trained counsellors on a helpline found that the assist-trained counsellors use more suicide intervention skills than the waitlist controls. However, minimal skill change was found in the STORM participants from pre-training to post-training and at follow-up. A little recap for you here. What I will note is that the training models that were used in the studies did vary a lot in terms of their content, their length and structure, and opportunities to skills practice, and whether or not there was a follow-up. Some emerging themes. So ASIST and CAMS both involve interactive training elements, so the participants will engage in a role play to have a chance to use their suicide intervention skills before going out to use them in practice. And a number of studies included in this review focused on counselling trainees, and 1 looked at social work trainees, and they were able to practice those skills within a supervised placement setting, where they've got the opportunity to embed those skills, reinforce them, and have feedback as well. And that's backed up by experiential learning theory that suggests that we learn better in that environment where we've got the chance to practice those skills. And again, that there's previous research by Cross et al. Which found similar findings across the community settings that suicide intervention training has previously been implemented in. In terms of the longevity of outcomes, confidence and self-efficacy appear to be the most durable outcomes over time, whereas the attitudinal, behavioural ones were more likely to decline. And again, that's consistent with research in community populations that Holmes and Hal found across a systematic literature review. And what's suggested may impact the attitudinal and behavioural decline is the system and organisation in which that is being implemented. So if the system isn't supportive, then it's harder to implement that knowledge and learning because it's not being reinforced over time. And that can be impacted by things like time constraints and high service demands or insufficient resources, but also attitudes from senior colleagues as well. So Some studies found a resistance to engage in training for thinking it's not needed, or refusing to embed that learning as well. So it really highlights the need for this whole organisation approach towards suicide intervention. What are the implications for the counselling field? Well, as we may be aware, in the UK, counselling isn't regulated on the statutory level. There therefore isn't any standardised suicide training across the board. There are efforts by ScopeEd, the framework, to try to standardise counselling competencies across the board. And within the framework, as well as in BACP best practice and the NICE guidelines as well, there are recommendations, again, for working with suicide minimum competencies, is looking at working in that collaborative way and focusing on safety and being able to assess risk. However, even though it's included in the minimum competencies, there's no actual outline of what a minimum standard of training should be for suicide intervention in order to be able to exercise those skills. Therefore, because of this lack of standardisation, I feel it's really important for further research to look at the UK landscape of the counselling population, at what our competencies are within suicide intervention and how we respond to that. There should be some more rigorous approaches to looking at this, so looking at RCTs and longitudinal studies to see the impact over time, but also adding in some mixed methods, to get that richness of the qualitative data of seeing how that training is actually being experienced by individuals as well. And that research would then inform a theoretically grounded training model tailored to the UK therapeutic practice. So we need something that's specific, that enhances that relational way that we work within counselling, alongside these existing models that are out there, to keep someone safe from suicide. And I'm calling for this to be standardised and mandated from core training, to have that experiential learning, so being able to actually practice those skills before going out and supporting clients, because a trainee counsellor's first client may be having thoughts of suicide, and we need to be prepared to respond to that safely rather than referring on out of fear. And this should be reinforced over time by ongoing CPD. So whether there's a minimum, whether it's every 2 years or so that someone needs to re-engage it in training to have that refresher, but also to be supported by reflective practice as well, to have that whole organisation approach and being in touch with how we are working. Some limitations to note: most of the studies were US-based with relatively small sample sizes, and the US and the UK are vastly different healthcare models. Also, the professions that were being compared have vastly different remits and training standards as well, so that needs to be taken into consideration when drawing generalisations. Likewise, a lot of the studies relied on self-report data as well, which is subject to social desirability bias, so there potentially needs to be some more studies looking at objective outcomes. Few studies actually include a control group, so most of them relied on pre and post data, so it was difficult to draw comparisons to treatment as usual or no training. And also some studies reported some ceiling effects as well, so it was hard to draw out any meaningful change across people that may have had some higher level of competencies at baseline, so that needs to be taken into consideration when drawing generalisations from the results. To conclude, suicide is everyone's business. It's widespread, but it is preventable. Counsellors and other mental health professionals play a very important role within being gatekeepers, especially within the relational nature of counselling as well, where we've got that real opportunity to connect with someone. Suicide intervention training can help to increase knowledge, confidence, self-efficacy and attitudes and skills towards responding to suicide, but more research is needed to clarify the landscape of the UK in terms of our levels of suicide intervention competency. and to reiterate that call to standardise and mandate suicide intervention training in the UK counselling context. Thank you so much for attending my session today. If you've got any questions, please leave them in the comments, and if you're interested in any references, please see the following slides. Thank you.